I will try to continue our discussion about this all multifocal and monofocal IOLs. I don't know if it's going to be the same direction that the other or before presentation, but we tried actually to examine, to evaluate the visual outcome after unilateral multifocal IOL implantation in our patients. We tried to catch for which patient can we propose these solutions. For the next forward. So we started with a series of patients undergoing cataract surgery, and we know that, as everybody says, the patients today are undergoing cataract surgery are more and more asking for spectacular independency after their surgery. So and we have also this new generation of multifocal IOL provided us good results, and it is reported in many studies with high rate of satisfaction among our patients, instead some with unhappy patients. But there's some question remaining for sure. The limited use of multifocal IOL could be or must be extended to other patients, to new patients, and we try to examine if it is possible to propose these multifocal IOLs for monofocal cataract, previously operated, or for younger patients. So we tried to do this study on a prospective, non-randomized during 6 months. We evaluate the use of unilateral multifocal IOL. We included some patients. I will show you what was the criteria. And we evaluate the clinical story of these patients. Also, the results were compared to a series of bilateral implantation in comparison. For this study, we choose 40 patients undergoing unilateral cataracts. The age of these patients were between 34 till 73 years old. There was 6 men and 8 women. One of the inclusion criteria was the emmetropia in the other eye. We choose this patient for that surgery. We clearly and completely informed and obtained the agreement of this patient for the study. For sure, we excluded all patients presenting any corneal or retinal diseases. If there were in the patient story pre-op refractive surgery, we excluded it also. And for sure, one of the reasons and one of the problems before the surgery was to determine if the psychological characteristic of the patient is an adaptive type, or if the patient demands are too high, we don't include it in this series. For the surgery, we used for sure a macrocoaxial surgery, non-astigmatogenous. With the main incision, what it was 1.8 millimeters. The surgery was done in the topical anesthesia. We do this normal and manual surgery without femtocillin. The IOL implanted was the Presbymania Plus, and I will say why we used this IOL. I will be pleased to one of our colleagues for sure, I think, Klaus. So one of the main reasons we use this IOL is that the power of the IOL is calculated. It is calculated very precisely, and when you give the manufacturer the number or the result of the IOL master, they give you a choice between several IOLs, and you choose the best one and the precise one for your surgery. Other advantages of this IOL was this IOL has a special design refractive surface, and so we have less visual symptom impending, and the better intermediate vision with that IOL. And also, as I said, the real power is provided by the manufacturer. Otherwise, this IOL are optically tested. Each IOL is provided with the MTF curve, and before the implantation, you can choose between two kind of IOL, and you choose the best MTF curve for your surgery. That's an example. So the MTF is at the left side is better than the right side for sure. And after that, we evaluate post-operatively these patients after 1 week, 1 month, and 6 months. They all go the slit lamp examination. The uncorrected vision and best corrected vision was examined. We also asked this patient to test the contrast sensitivity. We asked them if there was some subjective symptoms like halos, glares, and finally we asked them to file their satisfaction chart. Here is one graph representing our results, resuming our results. As you can see, the far vision were quite good with these patients, and the contrast also the contrast sensitivity. But some of them was remaining weak with the near vision. So the discussion after this result was that 75% were finally satisfied with their vision, but the majority of this patient, 65%, one multifocal IOL and phakic eye, the other one, achieved expected independency after their surgery. But these values were slightly lower than the values for bilateral multifocal patients. And then we compared this result to the bilateral implantation, and we find that the patient satisfaction was slightly different, with 7.3 for unilateral patient versus 8.9 for bilateral patients. So on the conclusion of this study, what we can see that it is that use of multifocal IOL for just one eye can be provided to some patients, but for sure the philosophy of multifocal IOL is needed for bilateral surgery, and it is for the binocular vision. So can we propose it? I will say yes to some, and you can propose it, but you get to choose very toughly your patient actually, because some patients will accept this vision easily, and the others will have glares and will have bad near vision. So the main thing is the discussion that you got to have with your patient before the surgery, and to explain why you're going to use the multifocal, because if they're not, you will do the surgery for the second eye, maybe 10 years, 12 years, or I don't know, several years after that. For sure you will use a multifocal IOL. For that, the future will provide us better multifocal IOLs, so it is time for us to use most often these IOLs in in our surgery, even if we have to do one eye only. And one of the reasons that we concluded after this study was that the use of unilateral multifocal IOL was a good provider of remaining the depth of focus, which is very important and very necessary to have a good vision for near, intermediate, and far vision. So, thank you very much.
Thank you, Dr. Amir. Did you find patients comparing both the eyes and have a greater subjective symptoms? Because they have a better eye to compare.
Unilateral and bilateral, you mean?
No. When you do only a unilateral multifocal implantation, do patients tend to compare it with a better eye and find more subjective symptoms of glare and halos and less contrast?
It was more or less the same one. Actually, the most problem where the main problem remains the transition between far and near vision for these patients. They don't the halos and glare is not the main problem in this patient. They are very weak with their intermediate vision actually. The transition between far and mainly for the patient before the age of 15. When the accommodation, when we got the accommodation actually. So they don't really want to have this vision, and they are more and more demanding the near glasses, even before age of 14, for example, to see clear for near vision. But the subjective symptoms as halos and glares are not the big deal with these patients actually.
Are there any comments, any questions from the audience? If not, I think we are ready for a coffee break, and we continue in the Polyclinic Building Conference Hall at 11:30. Thank you.